Hi, welcome everyone. We're so excited to bring you the highlights, the scientific highlights of the American Academy of Neurology meeting that we just attended in Boston. Dr. Kathrin LaFaver will be presenting these to us. Today, we're just going to focus on the science highlights in movement disorders. Dr. LaFaver is a neurologist in Saratoga Springs, New York. And Kathrin, welcome.
Thank you so much. Since we're both movement specialists, so that's of course our main area of interest. And it was hard to pick, but yes, we will be focusing on some of the scientific highlights. And first, I want to mention an abstract presented in the scientific session 42 from Genetics of Movement Disorders. And these were preliminary findings from the PD generation study. So as you probably know, this is a very, very large study that's been going on for a while now by the Parkinson Foundation. So James Becker, Chief Scientific Officer, presented the findings, dated frequency of known genetic variants for Parkinson's disease in the PD generation study cohort. This is really probably the largest scale genetic testing study and counseling study in Parkinson's disease. They aim to recruit 15,000 participants and have just hit their 50% target. And they're really trying to advance our understanding and treatment avenues for Parkinson's disease on these clinically relevant genes. And to date, we have found that 14% of participants were found to have a genetic form of Parkinson's disease. And it's actually higher than the previous estimate of around 10%. This is very exciting, and I think will help us in the future to identify who might qualify for clinical trials targeting specific genes such as VLARC2 or GBA mutation. And what's also really important about this study, they're really trying to increase recruitment of people in marginalized racial and ethnic groups. So 11% of their participants identified as Hispanics. And interestingly, in the Hispanic patients, 16% had a genetic link to Parkinson's, which is the highest rate of any ethnic group. So very interesting study, more to come.
Yeah, we're really excited at the VA to be participating, and we are definitely excited about the fact that they are specifically trying to recruit patients in various populations that haven't been represented: women, African American patients, Latin patients. It's really a great study, and I think if people are out there listening, if you have patients living with Parkinson's that are interested in participating in trials of any sort, please have them contact the Parkinson Foundation. It's a pretty easy enrollment.
Absolutely. I can only agree. All right, moving on to our highlight number 2. And this was from the scientific session 37 on phenotyping and biomarkers in Parkinson's disease. The study I'm talking about is the synuclein 1 study, skin biopsy detection of phosphorylated alpha-synuclein for diagnosis of synucleinopathies, and this was presented by Dr. Christopher Gibbons. So as we know, we don't have perfect biomarkers at this point for the diagnosis of Parkinson's disease, and a lot of the research is focused on CSF biomarkers, which is really important, but from a practical perspective for diagnosing our patients in the clinic, not always the most feasible thing to do. So in this SYN1 study, a standardized skin biopsy and 3 different sites was developed by C&D Life Sciences for detection of synucleinopathies. These 3 skin biopsies are then diagnosed for intraepidermal nerve fiber density and deposition of phosphorylated alpha-synuclein. Based on their data presented, the test was very sensitive and specific to detect phosphorylated alpha-synuclein. And of the over 400 patients enrolled in the trial, most of them, over 100, had Parkinson's disease, 59 had multiple system atrophy, 67 recruited had dementia with Lewy bodies, and the rest had pure autonomic failure. And they also recruited 151 healthy controls. So the main findings were that across all patients with clinically diagnosed synucleinopathies, the sensitivity was 95%, and the specificity was 96%. These were kind of broken up, and highest for people with MSA. We were actually able to distinguish between Parkinson's and MSA. There's also a recent paper in the journal Neurology published actually just on April 11 to go into more details on this. And I think one of the limitations I did want to mention is that the diagnostic accuracy was validated based on clinical established diagnosis and not pathology data. Regardless, this is a very promising test, but hopefully we will be able to use more and more in the clinic to help us with our diagnostic accuracy.
Absolutely. I agree. I think we're always looking for biomarkers. We've been on the hunt, and finding something that's easy and accessible in clinic is really the gold standard that we're looking for. So a lot of exciting news in the biomarker area.
In the interest of time, I want to highlight something in the therapeutic realm. And I just really picked one out of several studies. As we both know, with advancing Parkinson's disease, people have more motor fluctuations, struggle with more off time, dyskinesias. So there's several developments to go into more longer acting deliveries of carbidopa levodopa and dopamine agonists and so on. And so a specific study I want to talk about briefly today was presented during the Contemporary Clinical Issues plenary session with Dr. Ellen Bogan, and is entitled Safety and Efficiency of Continuous Subcutaneous Levodopa Carbidopa Infusion for Parkinson's Disease, 3-year data from the open label Beyond study. So most people in the movement realm probably know that this has been a longstanding goal to really deliver subcutaneous carbidopa levodopa, and there's a lot of technical issues around this. But in this study, the investigators have shown now that this is actually an effective and safe way of carbidopa levodopa delivery. The phase 2 clinical trial showed a 2.6-hour increase in on time without troublesome dyskinesias, and 2.5-hour reduction in off time at 12 months. Now they presented their 3-year outcome data and actually compared infusion over 16 versus 24 hours, and found that most people are actually okay with going over a 16-hour time frame, so they don't have to do the full 24 hours. And adverse events mostly occurred in the first year, and the most significant ones were infusion site reactions, which are fairly common in year 1 and mostly include subcutaneous nodules and hematomas, and really leveled off in year 2 and 3. And although these were fairly common side effects, did not commonly lead to discontinuation of the therapy. So this treatment is not FDA approved yet, but is one of the promising developments in helping people with motor fluctuations and dyskinesias.
Yeah, it's always good to get long-term data, isn't it? Because sometimes, the short-term data is not very reflective of really what clinical practice is going to be like. So that's a great study, and lots of new information coming out about all kinds of infusion therapies that we saw at this meeting, with APICAN pumps and, all kinds of really exciting things on the horizon.
Yeah, and it's good to have alternatives, especially for people who are not good candidates for surgical treatment. So more to hopefully come, and moving into the clinic hopefully soon.
Absolutely.
Well, I guess we want to switch gear a little bit away from Parkinson's, and I did want to speak a bit about one of the true controversial topics in our field, which is normal pressure hydrocephalus. It was actually one of the opening plenary sessions entitled Controversies in Neurology. Is normal pressure hydrocephalus overdiagnosed? And there was a very interesting viewpoint by Dr. Clifford Saper, who somewhat provokingly stated, because of the lack of larger placebo-controlled trials for shunting in NPH, he was actually calling for a stop to neurologists to even make this diagnosis, and ask people to stop any shunt placements until more study data is available. And so specifically, he was asking for a study where patients would be implanted with shunt in either the on or off position, and randomly turned on, and then rated by blinded raters 3 months later, and then go for the reverse scenario. So he was basically arguing that without having that data, that we really know this is a procedure that has longer benefits, we shouldn't be doing it. And he was calling the existence of idiopathic NPH in question. On Tuesday morning, this was kind of called in question by Dr. David Jones, who is co-director of normal pressure hydrocephalus clinic in at Mayo Clinic, and he led a extremely well visited course standing room only in the educational program, where he argued NPH is indeed very real and treatment can have long-standing improvement in gait and cognition. He did not show aggregated data, but he was essentially arguing the main problem is that the diagnosis is not often not made in a standardized way. And he gave many, many clinical pairs for people to exactly change that. And just to mention a few, really important to review brain atrophy patterns very closely, looking for markers of abnormal CSF dynamics, looking really at the pattern of ventriculomegaly, and large Sylvian fissures, and tight high convexity is very typical seen in NPH, and is good to assess this on sagittal images. And then another really important point made by him was to order an FDG PET scan if possible, because the question is often, well, does this patient have NPH? Is it Alzheimer's disease? And if you order an FDG PET scan, it'll answer that question for you. So if patients have a normal FDG PET scan, we have proven that they do not have an underlying neurodegenerative disease. And he showed many videos with a follow-up with convincing benefit on gait and cognition of over 8 years. So while this is certainly not the randomized blinded controlled trial Dr. Saber was calling for, I do encourage people to review some of Dr. Jones' recent publications on NPH, such in Continuum. And I know there's a lot of research going on, so hopefully they can move towards a more standardized approach towards this diagnosis and treatment.
Yeah, I mean, it is a very complicated area. I do think that when we find patients that we think have this and we can shunt them and make them better, we are always pushed to try to look for something that's very treatable. But I love those pearls. I think those are very, tangible things that we can kind of grasp onto. But I think the setting up of that randomized control trial and turning the sort of shunt on and off and in this blinded fashion, it sounds a little complicated. I'm not sure how, even the timeline of response is going to be in that sort of trial. So I think that, there may be some patients that are overdiagnosed, but I certainly think it's a real diagnosis, and that I know that we help people every day with these sorts of diagnoses all over, our practices. So
I agree. So to top it off, let's come to our highlight number 5. And switching gears again, I'm going to be highlighting Dr. Selma Ibeck's presentation on functional neurologic disorders. And she covered biopsychological trait markers supporting the stress diaphysis model in functional neurologic disorders, or FND. Of course, FND has been a long-standing interest of mine. As you know, there are many problems in making and communicating a diagnosis of a functional neurologic disorder. This is often seen by many as a rule-out diagnosis. This can be very costly and time-intensive. There's a stigma of the diagnosis. So the search for biomarkers has been ongoing. And in this study presented by Dr. Ibeck, she combined detailed trauma assessments, salivary cortisol diurnal biomarkers, and voxel-based morphometry in 86 patients with FND and compared this to healthy controls. The results showed higher emotional neglect scores in patients with FND, interestingly, a flattened cortisol awakening response, and reduced hippocampal and amygdala volumes, which were not correlated to cortisol levels. So the conclusions from her study was that she felt that the reduced hippocampal and amygdala volume was actually a predisposing factor rather than a secondary effect related to stress, and might put certain patients at greater risk for developing FND. Now, there's a lot of ongoing research on genetic and epigenetic changes in FND. And she actually published her research in this very nice study in Brain in November 22. So I will refer you to that for more details. And with that, these were my 5 highlights on movement disorder updates from the AAN annual meeting in Boston 2023.
Thank you so much, Kathrin. I think that the FND world has been changed by you and the work of many of your colleagues. I really applaud you getting this out there into the mainstream neurology conferences. I think there was a lot of exciting content, and I would urge people who are interested in this space, and we all see these patients, to go back and look at that content. I think you can watch it on AAN Rewind or other ways, but so much amazing content in that FND, functional neurologic disorder space. Thanks so much for watching with us and allowing us to highlight our exciting moments at the AAN of this year.
Thank you so much, Indu.